Assalamu alaikum. It's time to introduce our colleague, Dr. Mansour Al Somaily. He's a consultant dermatologist at King Khalid University Hospital and in Asir General Hospital. He's also participating and very active member in most of our activities. Dr. Mansour, I don't see him around. Okay. Dr. Mansour is going to address the role of abatacept in the management of psoriatic arthritis. Welcome, Dr. Mansour.
Thank you, Dr. Fahda. Bismillah, alhamdulillah, assalamu rasulillah. It gives me a great pleasure and honor to have this chance to talk about the role of abatacept in managing patients with psoriatic arthritis. When we are talking about psoriatic arthritis, we are talking about a very wide spectrum of musculoskeletal manifestations that include polyarthritis, oligoarthritis, DIP arthritis, axial involvement, arthritis mutilans, nail dystrophies, dactylitis, and enthesitis. The incidence, The incidence and prevalence of psoriatic arthritis is highly variable among the different populations. For instance, in Finland, the incidence of psoriatic arthritis is about 23%, while in Canada, for example, the incidence of psoriatic arthritis in psoriasis patient is 2.7%. This is the Casper criteria, where the patient need to fulfill at least 3 of them to score 3 or more points to be classified as having psoriatic arthritis. And as you know, you can now diagnose psoriatic arthritis even in the absence of cutaneous manifestations if the patient is having 3 or more points. For instance, if the patient is having family history in first or second degree relative with nail dystrophies and dactylitis, this is enough to classify the patient as having psoriatic arthritis. Initially, the people were thinking that psoriatic arthritis is not as aggressive or erosive as rheumatoid arthritis. However, now we realize that psoriatic arthritis is very progressive and erosive disease, and you need to retard its progression by DMARD, whether synthetic or biological DMARD, in order to prevent the sequelae, the complications, and joint damage. These are some of the cutaneous manifestations of psoriasis, guttate psoriasis, pustular psoriasis, and erythrodermic psoriasis. There are so many comorbidities associated with psoriatic arthritis, like cardiovascular diseases, diabetes, obesity, metabolic syndrome, and ocular diseases like uveitis. And by controlling psoriatic arthritis, you are also preventing the complications of these complications. Psoriatic arthritis and the quality of life. The quality of life is negatively impacted by the disease, and the burden of the disease is extending beyond the joint and including so many social and psychological aspects for the patient. For example, the risk of depression and anxiety and the sleep disorders are more common in psoriatic arthritis patients than the normal population. So many assessment tool has been validated in a patient with psoriatic arthritis and can be used as a surrogate marker to follow the disease response or activity. Some of these tools will be based mainly on the signs and symptoms of the patient, like the ACR 20, ACR 50 and 70, the DAS 28 with some modification in the joint distribution. Some of these scores are based mainly on the patient-reported outcomes like HAQ score and disability indices. And some of these tools are based on the structural damage, like the ultrasound scoring system and the methods, and the SHARP score. The first biologic approved in treating patients with psoriatic arthritis was infliximab in 1999, and then followed by other TNF inhibitors. In 2009, ustekinumab, the interleukin 12-23 inhibitor, has the approval in treating patients with psoriatic arthritis. Apremilast, approved in 2014. Apremilast is a phosphodiesterase inhibitor. Secukinumab, approved in 2015, and more recently, abatacept in 2017. So we have so many drugs has the approval in treating patients with psoriatic arthritis. We as a clinician, we have to have a scientifically acceptable view to individualize our patient and to choose the appropriate therapeutic strategy. Most of these biologics and phosphodiesterase inhibitor and the targeted synthetic therapy were used in combination with conventional DMARDs like methotrexate. Just here is a quick review over the EULAR 2015 recommendations for treating patients with psoriatic arthritis. After you establish the diagnosis, start NSAIDs with or without local corticoid. I don't know the pointer here is working. It seems the pointer is not working. So after you establish the diagnosis, start the patient on NSAID with or without local corticosteroid. If you achieve the target within 3 to 6 months, continue your therapy. If the patient is having inadequate response or the patient developed toxicity to these drugs, start methotrexate or its alternatives like leflunomide or sulfasalazine. If you achieve the target within 3 to 6 months, continue your therapy. If the patient has inadequate response or he or she developed toxicity to your therapy, or the patient is having axial involvement, then you can start the biological treatment like TNF inhibitor, secukinumab, or ustekinumab. If you achieve the target within 3 to 6 months, continue your therapy. If you didn't, switch to other biological agent. Here is a comparison between the EULAR 2015 and the GRABA 2016 recommendations. There are a lot of similarities, however, there are some minor but valuable differences. For instance, in treating patients with peripheral arthritis, in patients with psoriatic arthritis, you are recommending to start with NSAIDs, then glucocorticoid, then conventional DMARD, then if there is inadequate response to consider the biological agent. While in GRABA, they are recommending to start conventional synthetic DMARD in all patients with peripheral arthritis, and if there is lack of response, you can add the biological agent. Regarding the axial disease, there is a universal agreement about the failure of conventional synthetic DMARD in controlling the axial manifestation of psoriatic arthritis. So you can start your patient on NSAIDs, and if it is not effective, you can add the TNF inhibitors. Dactylitis and enthesitis, actually the optimal treatment for such patients remain uncertain. However, the EULAR recommending to start NSAIDs, and if it is not effective, you can add glucocorticoids or TNF inhibitor. However, the GRABA, they are not advising or recommending to start NSAIDs or glucocorticoid for dactylitis or enthesitis. For dactylitis, they are recommending to start conventional synthetic DMARD and then biological agents. And for enthesitis, to start immediately the biological agent, because the NSAID and the conventional synthetic DMARDs are not effective in such patients. With regard to the nail disease, there is no recommendation from EULAR, but the GRABA, they are recommending biological agents. Here are the poor prognostic factors in patients with psoriatic arthritis, which include high tender and swollen joint counts, joint damage at baseline, increased level of inflammatory markers like CRP and ESR. Abatacept, as you know, is a T-cell inhibitor. For full proliferation and activation of T-cell, you need to stimulate a co-stimulatory receptor on the surface of the T-cells called CD28. For the activation of T-cell, you need to stimulate the antigen-presenting cells like dendritic cells, macrophages, or natural killer cells. There is a co-stimulatory receptor on the surface of the antigen-presenting cells called CD8086. the Orantia or the abatacept is blocking the CD86, so it is indirectly inhibiting the T cell proliferation. Just here, I will discuss with you the Astria trial, which is a randomized control trial, where they have include 424 patients. All of them were adult with active psoriasis and psoriatic arthritis, and all of them, they have received at least one of the non-biological DMARD at one stage of their disease course. The patients were equally randomized into two groups, abatacept, 125 subcutaneously weekly, or placebo. The patients were assessed at week 16, 24, 44, and 52. The primary endpoint was ACR20. The secondary endpoint was HAC score, ACR20 in TNF inhibitor naive and TNF inhibitor experienced patient. ACR 50 and 70 also were in the secondary endpoints, as well as dactylitis and enthesitis. They have allowed and permitted open label period at week 24 in those who failed to achieve the ACR 20. All efficacy analysis used the intention to treat population, and they have also considered all the confound factors that might influence the result, like use of other DMARDs like methotrexate. These are the demographic data. It is almost equal in both studied group, except for marginal increase in the number of patients with enthesitis and dactylitis in the abatacept arm. Here are the result, ACR20 response at week 24. Abatacept is represented by the green bar, and the placebo represented by the orange bar. And you can see here that the almost 40% of patients who received abatacept, they have achieved the ACR20, while 22% of those who were on placebo, they have achieved the ACR20. So there is a clear superiority for abatacept group over the placebo, and it was statistically significant difference. The response of the TNF naive patients was more pronounced than the TNF exposed patient. The ACR 50 and 70 also was, the response was also superior in the abatacept arm over the placebo. However, it was not statistically significant difference. The ACR20 response at week 44, after they have shifted those who didn't achieve the ACR20 at week 24, after they have shifted the placebo group to abatacept, there is improvement in the placebo arm, and you can see that the difference became minor, and the response, the ACR20 response is much better after they have added abatacept to this arm. So there is a clear superiority for abatacept group over the placebo at week 16, 20, and 24. There was also a numerical superiority for abatacept over the placebo in the disability index and HAC score, and also in the enthesitis and dactylitis. Almost 30% or a third of the patients who were on abatacept, they showed the complete resolution of their enthesitis, while almost 20% of patients who were on placebo, they achieved this. 44% of patients who were on abatacept, they have complete resolution of their dactylitis. However, all of these differences were not of statistical meaning. The DAS28 also, there was a reduction in the DAS28 CRP in the abatacept group, better than those who were on placebo, but again, this was not of statistical significance. With regard to the safety result, as you know, abatacept has an established acceptable safety profile from the previous trials, and this has been also observed in this trial. There was no safety concerns or signals in this trial, the abatacept was almost equal to placebo in terms of adverse events, serious adverse events, infections, bronchitis, malignancies, and autoimmune disorders. So you can observe here from the figure posted there that there was no difference between the abatacept and placebo in terms of adverse events. The other indications for abatacept, as you know, is the rheumatoid arthritis with both preparation, the subcutaneous and the IV preparation, GIA, and the adult psoriatic arthritis. Abatacept, as you know, should not be used with any other biological agent. Hypersensitivity has been reported very rarely, in less than 0.1% of patients who received IV abatacept. Infection, it was, as I mentioned earlier, it is what was almost equal to placebo, the risk of infection. However, serious infections has been reported. Immunizations, the live attenuated vaccine are contraindicated in any patient receiving any kind of biological agent. COPD, abatacept should be used cautiously in patients with COPD because of the risk of infection and COPD exacerbation. Regarding pregnancy and lactation, still we have inadequate data, so this drug should be avoided in such patients. It is not recommended to be used in this group of patients. Malignancies, as I mentioned earlier, the risk of malignancy with abatacept was equal to placebo. The most frequent malignancies reported was lung cancer and lymphoma. The most frequent adverse events were headache, upper respiratory tract infection, nasopharyngitis, and GI upset. Conclusions, at 24 weeks, ACR20 responses were significantly improved with abatacept compared with the placebo, and the responses extended to week 44. 60% or more of patients had prior exposure to TNF inhibitors. Abatacept showed overall beneficial trends across musculoskeletal measures. Both subgroups, TNF inhibitor naive and TNF inhibitor exposed, showed clinical benefits with better responses in the TNF inhibitor naive subgroup of patients. Abatacept's safety profile was consistent with the previous studies in psoriatic arthritis and rheumatoid arthritis with no new safety signals. Greater improvement in DAS28 CRB from baseline to week 24 with abatacept versus placebo was seen, supporting the efficacy of abatacept in reducing arthritic manifestations. Abatacept, with its selective modulation of T-cell co-stimulation, may offer a novel treatment option for psoriatic arthritis patients, especially patients with predominantly musculoskeletal manifestations. Thank you for your attention.
Thank you, Dr. Mansour. Very nice summary about abatacept with psoriatic arthritis. Any question? Yes, doctor. Can you please introduce yourself to the audience before your question?
دكتور محمد كامل، شكرا دكتور منصور على الانفورميشن اللي حضرتك جبتها لنا بالنسبه ان الاباتاسيت can be used in treating patients suffering from psoriasis and arthropathy. You know, abatacept is very good medicine.